Good morning from Austin, Texas at the COS meeting. I'm pleased to be here with Dr. Liz Yu. Good morning, and thanks for being with us.
Good morning. Thank you for having me here.
This is a great meeting, Liz, especially because we get to talk about a lot of different topics that are new and are also a combination of some interesting topics in and of themselves. One of the more interesting things at this meeting that I think we'll be approaching is people who are coming in asking for presbyopia correction with their cataract surgery, who also have concomitant corneal disease, especially ocular surface disease, because that's a real challenge for us. How do you go about approaching these scenarios?
Yeah, absolutely. Preoperative selection and that counseling and education is so key. I mean, we have to remember that vision and the blur from vision issues due to a cataract is such a small piece of it, right? After whatever we do for them, the quality of what vision they have is something lifelong. And 2/3 we recognize to 3/4 of patients coming in have dry eye disease to some degree. So I am looking for ocular surface disease in every single patient in different ways. I'm looking at it with the objective data, seeing if the placido disc topography looks good, obviously on the ring image, and also looking for consistency with the amount of astigmatism, the average corneal power amongst the different diagnostics, because if they're inconsistent, that's more suggestive there is evaporative disease. And I'm getting my biography and asking a questionnaire on every single patient, because there is that disconnect, right, which makes dry eye even more confusing. Dry eye is not just staining with fluorescein. And then my biography, because so many of these patients that are coming in, they're looking for certain options, especially baby boomers, right, for some spectacle independence. But I'm meeting them for the first time, and I need that snapshot in time to understand where they are in their potential disease process, because it does make a determination as to what options I will offer them, whether it's single vision only versus combining a monovision with single vision lenses, or can they get potentially a presbyopia-correcting lens option to enhance their optimal, freedom from spectacles.
Yeah, those are some really important points, Liz, and I want to unpack a couple of those topics.
Sure.
Mostly, I want to start out with talking about in-office testing. You mentioned placido disc topography as an important way to evaluate the Myers. You mentioned matching up astigmatism on various different devices, including biometry and perhaps auto-Ks and some other important ways to measure that. And meibography, which is a great way to evaluate the meibomian glands. I'm wondering, do you also employ other point-of-care tests in part of this workup, and when do you decide to do that?
That is an excellent question, because as Alice Epitropoulos has shown, when you do have tear osmolarity that is addressed when it's not normal, the K values are more accurate post-treatment of dry eye disease. The problem is with reimbursement, certainly. Tear osmolarity has great value, both in positive and negative values of the osmolarity, because it lets you know, kind of your differential of what could be the source of the ocular surface disease, especially when you know that ocular surface disease is present. Mm-hmm. But to preemptively test every surgical patient, if you are willing to eat the cost, and the cost is not a huge one, but it's still, when you are thinking of it that way, you cannot bill patients for that preemptively unless they're walking in with a diagnosis of dry eye disease. So that makes it a little tricky. Not that it is not valuable, but certainly looking for these kind of nuances and really asking, of course, and trying to tease out the difference between fluctuating vision and the baseline blur. Fluctuating vision with activity, that is a huge trigger on top of what else you are seeing on your diagnostics to really address that. And really, when I show them my biography and show them what that dark image because of truncation or atrophy is compared to white, where you would have full glands, that really speaks volumes.
Yeah, I think that a lot of times speaking with patients about issues can be helpful, but showing patients the problem really drives home the point and can oftentimes get a lot more resonation on the issue.
Yep.
So then, Liz, let's talk about clinically how the approach is. If you have somebody coming in who's referred to you for a cataract evaluation, it's your first time meeting them, and you're identifying some potential ocular surface disease on your testing and your history, how then does the discussion go with that patient? Because it seems like this opens the door for confusion. I came to you for one problem, and now it turns out I have a different problem.
Sure. So certainly, connecting all that information with the clinical exam. And I really believe in doing a good, thorough lid exam, but that look, lift, push, pull of the gland, so LLPP with the ASCRS Cornea Clinical Committee algorithm, that is something I employ before I put any kind of vital dyes. But once we put that picture together, you've given them a diagnosis, there's moderate MGD, there's some staining, you want to see, first, can we turn around the ocular surface? So when I do any kind of acute treatment, it's more, yes, of course, it's therapeutic because I want good measurements, but it's also diagnostic. If they're recalcitrant, they come back in 3 weeks. I do a steroid taper. I've started oral omegas, which I know will take a little longer in time. I may have employed BlephX, which is microblepharoexfoliation. I may be doing these things, and if their measurements for diagnostics are still pretty bad, this is definitely going to rule out the use of a presbyopia-correcting lens. Now, if it makes a splendid difference, they come in with pristine photographs that are very consistent amongst your devices, then I know, absolutely, and they have a 20/20 macula, then yes, we can consider moving forward, but the caveat being, you will have a social contract with me that you're going to probably have to maintain something. Oral omegas, maybe annual lid treatments, maybe warm compresses and lid hygiene or something like that. And you may need RX treatments to maintain at baseline. If they're willing to do that, then I am certainly willing to broach that topic of using a presbyopia-correcting lens implant.
Good, and it seems like it seems like setting the stage beforehand,
Yes.
before the surgery, really seems to get you a long way with this. Discussing what your expectations are,
Yeah.
what you're seeing on your examination and your office testing, really can help to set the stage for this. I want to shift gears for a moment, Liz, and speak a little bit about the new generation of presbyopia correction, or the things that we may see in the pipeline coming to the U.S. soon. Can you speak to current presbyopia correcting technology and speak to what we may see in the future and how this may affect this discussion?
Sure. I mean, as you know, even domestically, when we think about it, from a surgical correction option standpoint, we have less than 10 options at this point, really, and not really a whole lot non-surgical. But it's so exciting to see that in the next 5 years, it is going to be so booming. And, and some surgeons, they fear, will the introduction of, let's say, some of the presbyopia correcting drops, is that going to actually hinder surgical kind of adoption? And I think it's actually going to do absolutely the opposite, because a lot of these drops are going to be great for that early presbyope, those who are up to 50, 55, especially if you're a little bit on the myope side, to offer that extra depth of focus and range of vision. But then they're going to say, well, one, they don't want to use drops. Two, they want to make this permanent. And now we will be able to. It's exciting to see that femtosecond laser may be able to either adjust the lens or adjust the cornea to create greater multifocality. Certainly pixel with cross-linking, another approach which is less invasive. Allogenic corneal inlays, which is being worked on as well by Allotex. And then finally, with our presbyopia correcting lenses, there's going to be a little bit more of that simple, easy button as it relates to talking about focal points, as our trifocal with the PanOptix is going to come to fruition likely early next year. And then for the non-perfect cornea, we have the AcuFocus IC8, which is just wrapping up their clinical trials. So certainly, I mean, this alone, just that breadth of what we'll be able to help our patients with, from the early presbyope with non-surgical through surgical options, I think the next 10 to 15 years are, honestly, we keep saying that, but this next generation, I think, will be quite exciting.
It's a real exciting time to be a cataract surgeon.
Yeah.
Liz, thank you so much for sharing your expertise today.
Thank
This is
you.
a topic which we could talk about forever, but I think we hit some real salient points here. Thanks again.
Yeah. Thanks for having me.